Welcome to the Sports Docs podcast with Dr. Catherine Logan and Dr. Ashley Bassett. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so that you know which literature should actually impact your practice. Hi, everyone. Before we kick off our episode today, we must start with some sad news. The orthopedic community suffered a tremendous loss this past Friday with the passing of Dr. Freddie Fu. Dr. Fu was a giant in the field of sports medicine and touched the lives of countless patients and athletes around the world. He mentored generations of orthopedic surgeons, many of whom went on to also become leaders in the field of sports medicine and carry his legacy onward. Thank you, Dr. Fu. You will be profoundly missed.
On today's episode, we're focusing on blood flow restriction therapy, or BFR. Blood flow restriction is one type of ischemic therapy that is thought to increase muscle mass, strength, and performance at a lower level of resistance training. And that last part really is key, because training at high loads is often not possible for our patients undergoing rehab for an injury or postoperatively.
We're joined today by Dr. Edward Chang, orthopedic surgeon and director of research at Innova Sports Medicine. Dr. Chang recently won the O'Donoghue Sports Injury Research Award for his work on the use of BFR after ACL reconstruction, so we're very excited to have him join our discussion today.
We have some great articles for you today that contribute well to our conversation on the use of blood flow restriction therapy for both routine training and after musculoskeletal injury or surgery. As always, links to all the papers that we discuss on this show can be found on our podcast website.
The first article is a systematic review recently published by Mary Mulcahy and colleagues in the June issue of AJSM this year, titled Blood Flow Restriction Training in Athletes. This paper analyzed the effects of BFR training compared to traditional resistance training in healthy athletes. 78% of the included studies reported a significant increase in muscle strength after BFR compared to traditional training. 3 of the 4 studies that evaluated sports-specific performance reported significant improvements across various running, jumping, endurance, and agility tests compared to controls. The effect of BFR on muscle mass, however, was less clear. Of the 8 studies, 50% found a significant increase in muscle size, while 50% reported no difference between the groups.
Our second article is a laboratory study from the November 2020 issue of AJSM titled Local and Systemic Effects of Blood Flow Restriction Therapy in an Animal Model. Beatty and his team at the University of Michigan developed a rat model to evaluate 2 types of ischemic therapy, one with and one without low-load exercise, compared to 2 control groups without blood flow restriction, with and without low-load exercise. Low-load exercise was simulated at 50% of maximum contraction or 1 rep max by nerve stimulation.
While no differences were found between the 2 control groups, which is expected given the low-load exercise at 50% 1 rep max, there was also no difference across all measured variables after the 2 types of ischemic therapy. Compared to controls, there was no difference in muscle mass, maximum force output, myocyte cross-sectional area, and muscle satellite cell density. The authors concluded that both forms of ischemic therapy did not result in muscle hypertrophy or improve muscle function compared to controls.
We're excited to have Dr. Eddie Chang join us for the discussion today. Dr. Chang is an orthopedic sports medicine surgeon at Innova Sports Medicine. He is an assistant professor of orthopedic surgery at UVA School of Medicine. Dr. Chang earned his medical degree from Rutgers University, Robert Wood Johnson Medical School, and completed his orthopedic residency at Thomas Jefferson University. He then went on to complete a fellowship in sports medicine at the University of Pittsburgh. Dr. Chang is currently the Director of Research at Innova Sports Medicine and has published numerous peer-reviewed articles and book chapters. He recently presented his research on the use of blood flow restriction therapy after ACL reconstruction at the AOSSM annual meeting this past July and won the O'Donoghue Sports Injury Research Award. So we're definitely looking forward to hearing his thoughts on this topic.
So Eddie, welcome to the show. Thank you so much for being here today.
All right, thanks for having me. Happy to be here.
Good. So I thought we would start off with you giving just our listeners a quick overview of blood flow restriction therapy. Like, what does it involve? How do we think it works? How does it benefit our patients?
Great. So I guess in a nutshell, blood flow restriction is applying a tourniquet on your proximal limb, so whether it's upper thigh or upper arm, and inflating it to some sort of desired pressure. And we could talk a little bit more about that later. And what the overall goal is to reduce arterial inflow to the distal extremity, but more importantly, it actually severely reduces venous outflow. And so that's the main idea of BFR, is that you still get a little bit of arterial inflow, but it's really keeping all the venous blood pooling distally, and creates a anaerobic environment, which then in turn hopefully then leads to muscle hypertrophy.
Yeah, I think, we've talked about this before, as far as, your experience, and, you've been using it longer than most. So can you talk a little bit about your specific experience with BFR and who you think benefits most from it? Like, are you using it mostly with non-operative, with operative, with all comers? How do you think about it in implementation?
Yeah, that's a great question. I first came across BFR when I just started practice about 6-7 years ago, and one of my senior partners, Dr. West, who you had on last time, she was using on her baseball pitchers, and I talked to some of the athletic trainers, and we really didn't understand. I asked them, like, what is this blood pressure cuff they're using, and they tell me a little bit more about what BFR was, and how that by doing this, even though it was supposed to help distal extremity issues, they are feeling better in the shoulder. And it got us thinking a little bit more. I did a little bit more research about it. And what I usually use BFR for, who I think it's most indicated for, is kind of the early post-operative patients. And so people that can't do a 1 rep maximum of 70% or more. And so that then leads to muscle atrophy, and which then can lead to a whole host of other problems. So I think implementing BFR early on in the post-op period is probably my number one indication. I think other indications would be patients that come in with some sort of previous injury, and just you just see a big difference between the two quads. You send them out to physical therapy first. You may not do BFR initially, but you get a note back from the therapist, or they call you saying, I just can't seem to get their quads to fire. I tried e-stim, I tried needling, you've done all these type of things and it doesn't seem to help. That's when, maybe we consider doing BFR as well.
Do you feel like there are certain postoperative patients or certain surgeries that you do that benefit the most from BFR? Like, I know your research is on ACL, but like for upper extremity, like, do you feel like cuff does really well, or are there some ones that jump out to you like all these patients should be doing BFR?
So my personal feeling is yes, I think most early post-op patients should be using BFR. I don't have a lot of experience with upper extremity yet. I know there's some research coming out, and if you look on clinical trials on the website, there's a lot of BFR trials going on right now, upper and lower extremity. But my upper extremity, I don't have a lot of experience with. Lower extremity wise, I don't think you need to do on everybody. Standard partial meniscectomy, I think most patients can get their quad. You check them for 1 week post-op, and they're generally walking in. You can't even tell that they had surgery sometimes. So I don't think those patients need it if their quad fires. But I do think more of the reconstructive knee surgeries, patients that may have delayed weight bearing, or those are the ones that I think really would benefit from that. So yeah, a fair amount of my patients I recommend BFR for.
So this is a little bit of a side note, but it comes up a lot. And I feel like while we have you here, it's a good question. When you're doing your meniscus repairs, what's your thought strategy with non-weight bearing? And when do you let them weight bear? Do you think a lot about, is it a specific time? Is it a size of the tear? Those types of things. And then, because also this is a time where BFR I find is very useful.
Yeah, I think there's a lot of debate about when you should let patients weight bear after meniscus repair. And my traditional thinking is if it's a longitudinal repair, especially if it's a smaller vertical tear, I generally let them weight bear as tolerated, locked in extension. You just don't want them to flex their knee and to have that rollback on the meniscus. But patients that have meniscal root repairs or radial type repairs that you do, especially the ones that go very peripheral, those are the ones I tend to restrict weight bearing for at least 4 weeks. A lot of papers say 6 weeks, but I find a lot of my meniscal root patients just are generally, they're not 20 or 30. They're usually 45 or older. A lot of them generally on the heavier side, and they just can't seem to tolerate, being non-weight bearing that long. So I usually start doing, protective weight bearing about three weeks or so. And I think, yes, all those patients probably would benefit from BFR because they can't, if you're not weight bearing, you're really going to be a lot of disuse in that quad and can lead to atrophy. So I think, doing something non-weight bearing with BFR, just even simple things like quad sets and straight leg raises would be really helpful.
Yeah, for sure.
You mentioned early postoperative period, but I feel like a lot of these BFR papers say, they started at 8 weeks or they started at 10 weeks. And I feel like most people I'm talking to are starting BFR quite early on. So how early do you start it? Is it like after the first post-op visit, or is it a few weeks?
Yeah, I think that's the really key point about BFR is that, again, they say muscle growth occurs when you're at 70% of your 1 rep maximum. And when you're at 10 to 12 weeks post-op from, let's just say, an ACL reconstruction, you're almost about ready to let that patient start to run, which means they're able to tolerate high loads and be able to get the muscle hypertrophy that you need. So BFR may not be as important at that time as it is a lot early on. And so I think that's something that we should be thinking about more is, BFR is not really for the people that are, elite athletes that are in prime physical shape, even though they ask for it all the time. I think it's probably the best use is in kind of the patients that are early post-op or have some sort of, delayed weight bearing or, some sort of other medical condition that they need it for. In terms of when I start my patients, the manual, or if you talk to Johnny Owens, he says to start BFR around, 10 to 14 days out from surgery because he wants the incisions to heal. I don't really know the science behind that, why you really need to wait that long for, blood flow restriction for 3 minutes. Mm-hmm. But so I've been actually trying to start that a lot earlier. So most of my patients after knee surgeries go into PT about 3 to 5 days post-operatively. I try to get them in within 3 days after surgery, and generally their second visit, which is post-op day 5 to 7, we'll try to implement BFR at that point. And I haven't really seen any major, I guess it's wound issues. It's probably the number one thing he's concerned about, but I guess some patients may not like the feeling of the tourniquet on them that early on if they're still recovering from, pain in their knee.
For sure. Yeah. So that sort of lends to, I'm sorry, Ashley.
No, I was just going to ask what you do, because I know you use BFR a lot. Is yours similar? Usually 10 to 14 days, or are you holding off a little longer?
No, I would say pretty similar. And I agree with you, Eddie, where you sort of say, I don't know the science to say that there would be a wound healing issue. So I think it's more just, could they tolerate it? Are they still sort of, just that early recovery of okay, this was just like a big whack of a surgery and I just need to settle in a little bit and start with some basics of quad setting and some motion or, some edema reduction. But I'm also just curious, does it help their edema reduction? Does it, just sort of having that contraction, does that facilitate any of that? And for ACLs, I tend to do a lot of quad. So I also wonder, are they still pretty sore there? Is it a little too early? But I'm not necessarily worried about them doing it as far as wound. But, I think most people are they're a little uncomfortable that first 5 days or so, where maybe it's just too early just from a tolerance.
Yeah, I agree. I have all our therapists at where I'm at are trained in BFR. And so they all have a good, it's been about 4 or 5 years now since they've been using it. So they all have a good idea of which patient, when they see them, their initial eval, and he's a young kid and, ready to go. I'm all about this BFR thing, especially if the doc already mentioned it to me, and they'll probably try it out, within 7 to 10 days post-op. But if you have somebody that is in, CRPS and immense amount of pain post-operatively, you're probably not going to put a tourniquet on their leg that early on.
We'll be right back.
We're super excited to let Sports Docs Pod listeners know about an opportunity to receive a $20 discount on a truly awesome Lots Fit mini massage gun.
So let's tell you more about it. The Lots Fit Mini Massage Gun is an easy-to-use handheld massage device. It comes with 4 different head attachments for different types of massage: whole body, focal pain points, or spine. It even comes with a heated head attachment for maximal relaxation.
I keep mine charged at my work desk and I use it after a long day in the OR. Oh, and you can get it engraved. Mine has my name.
The Lots Fit Mini Massage Gun is really great to use after a long workout, especially after my husband kicks my butt in squash.
Well, he is a professional, Ashley. We'll put a link in the bio, or you can go directly to lotsfit.com, lotsfit.com, and check out that mini massage gun and enter the discount code Dr. Logan, DRLOGAN.
Welcome back.
Yeah, I feel like PTs that are really, really good at it, really comfortable with it. I've actually started having my prehab included for ACLs, and I feel like then the kids know what to expect. They're like, "Oh yeah, that torture device. Yeah, no, I'm ready for it." They're like, "Yeah, no, it's not fun, but I'll do it." And then they start it right after because they know what to expect, and they're like used to it. They're used to what the machine is and things like that. Some other people maybe not, but I feel like for ACL prehab, it definitely helps them. I think regain their quad quicker, and then for post-op, then they're used to it a little bit. We can start it, week 1 after the surgery.
That's a great idea. I haven't, there are a couple of studies in that you guys pulled earlier that mention doing it, preoperatively as well. Don't show a significant benefit, but I really think you have a traumatic injury like that, you get an infusion, and we know infusions shuts down your quad. Can BFR be a good way to keep that thing going so it doesn't prevent, so it prevents atrophy, from injury to surgery. Because we know it's gonna, your quad's gonna atrophy after surgery as well. So can you try to prevent that from happening until you get to surgical reconstruction? So that might be something I'll look into maybe adding to our therapy basic protocol for prehab, because we don't do that right now.
Yeah. I think you're right, Ashley, too. That's a good point, just the mental piece, saying, okay, because it's very different than anything else they do in rehab. So just having that little bit of exposure probably takes away a lot of the anxiety around it.
Yeah, definitely.
So we were kind of touching on with that topic, like contraindications. So not everybody listening is obviously very familiar with BFR. So Eddie, can you walk us through what you'd consider contraindications to BFR?
Yeah, so a lot of patients will ask about side effects for BFR, and there is a great Japanese paper that was published 10 years ago, looking at 13,000 patients, and they found the most common things are discomfort, bruising, dizziness, which I've had one patient actually tell me they felt a little bit lightheaded afterwards. Mm-hmm. I don't think those are contraindications as much as those are just some adverse side effects that patients see. I think patients that have some sort of cardiovascular disease, I don't really do, and it's not really our population, but you might get a couple patients that have that, and because it does drive a reflex sympathetic response. Mm-hmm. And it's brief. So they did a bunch of studies saying maybe it's about 20 or 30 minutes post BFR, you have that sympathetic drive, but that increases heart rate, increases your MAPS. And so, those hypertensive guys you want to stay away from. I think patients with some sort of venous insufficiency or vascular issues like varicose veins, there haven't been any bad reports about that, happening, but something about, keeping all that down there in patients that have already some sort of superficial vein issue, I would maybe consider avoiding as well. Some other papers say, maybe contraindication in crush injuries. You don't want to take away blood flow from an area that's, having issues and then do some sort of second hit reperfusion. So I think that's another contraindication. Other obvious ones would be open fractures, things like that. But I don't think we're at the point where we're doing BFR on that, but it's in the review papers. And so I think I just want to mention that, but for the most part, it's kind of the medically sick patients with cardiovascular disease.
So speaking of contraindications, what about skeletally immature patients? So like two scenarios, like a 13-year-old that you just did an ACL reconstruction on, but then like an 8-year-old you just did like an OCD fixation on. Are you pausing at all because of the open growth plates, or are you not concerned?
So I don't take care of a lot of that young peds in my practice. I do some open physeal, ACL type surgeries, and we can talk about this later. But we, in our study, we did include patients 13 and above. So and they tolerated just fine. And so in my practice, I guess the youngest ACL I've done is probably 12. They will get BFR, and I've been okay with it. But something as young as 8, I don't know much about. I can't imagine it, being bad. But at the same time, you got to study it.
I brought this up because I actually called Catherine about this when I was doing a BFR routinely, and I had this run of like 13-year-old girls that like all tore their ACL. And one of the moms said, well, blood flow restriction, I don't know about that. The PT said, where I'd recommended it, that it cuts off blood flow, and because she's still growing, we shouldn't. And so I did a literature search, and there was nothing. None of the studies included skeletally immature people. So I remember, Catherine, I asked you, and you said, well, there's not a lot of data. So I'm holding off for now. Now I'm hoping we get more data, because I think a lot of those 13-year-olds, 12, and thankfully your data contributes to that. Yeah, that's a lot of our sports patients sometimes, and I feel like BFR shouldn't be withheld from them. So happy to hear that 13 was included in your study.
Yeah, we even before we started doing our study, we were doing them already in younger kids, with open physis, and they've been fine, and we haven't had any adverse issues. I guess we probably would have to kind of map that out long term and have higher numbers, but we haven't, the therapists and my partners haven't really noticed anything that's wrong doing it.
Good to know.
So one of the papers that we're highlighting is the systematic review by Dr. Mary Mulcahy. So it obviously talks about the benefits of BFR, but it also sort of highlights how variable all these protocols are. And Eddie, you and I were talking about that earlier, just how the protocols vary a lot, and it's really hard to compare across studies because they are so different. So how do you sort of develop your own protocol? Where have you pulled it from? Do you how much of tinkering is it on your own and, with your therapist? And can you tell us a little bit about how you built your protocol?
Sure. So the protocol that I used and the concept behind it was by Johnny Owens, who is really one of the guys really pioneering BFR in the US. And so I met with him a few years back, and he just kind of went over what he did and how he trains, because he does a lot of training for BFR as well. And so we kind of learned from him, what to do. So I don't tinker a lot off of what he recommends. So the one thing I probably do is I start BFR maybe a little bit earlier than his, 2 weeks post-op and after incisions are healed. Other than that, everything else is pretty standard from what he recommends, which is, when you apply the BFR, you want to do 80% in the lower limb, 80% of the arterial occlusion pressure. And you do the exercises, 30 repetitions, 30-second break, then you go 15, 15, 15 with a 30-second break in between all of them. And so I basically follow that 2 times a week in PT. And generally for ACLs, which is what we do mainly on, we stop around 4 months post-operatively unless the patient wants to continue doing it.
Okay. And you mentioned earlier, meniscal repairs, and a lot of what your population is for root. So when you're having that sort of population, do you notice that you have to modify? How are you changing it? Those sorts of things.
In terms of when I started, or
I'm sorry, I should be more clear. Like, is that too many reps? Is that hard to tolerate? Is it
I see.
rest breaks? Because an ACL who's 22 versus a root repair who's 45, can be quite different depending on the population.
Oh yeah, so that's great. So the way I progress them in terms of exercises is, and this is something we develop with all the therapists as well, is you start with simple quad contractions and quad sets. Mm-hmm. So they have to be able to demonstrate that they can do that. and do the 30, 15, 15, 15 with that before they could then progress to a straight leg raise.
Okay.
And at 4 weeks out post-op, they're generally allowed to weight bear a little bit more. Then I start to do wall squats, 90 to 45 degrees or something like that. And then from there, you can then progress to lunges at, more at 8 to 10 weeks out, deeper squats, and leg press as well. And so if the patient, they all have to follow that graduated protocol. And so if a 16-year-old kid that had a reconstructed knee can do it, within, a week or so and demonstrates no lag on a straight leg raise, then we can go straight to straight leg raise, post-op week 2. If a 45-year-old root repair is still struggling with a quad set at 3 weeks out, we just keep firing that away because you don't want them to feel discouraged or even cause some kind of issue if you try to push them along just because the protocol. A lot of docs would just say follow protocol, right? But you want to actually let the therapist know, and they should know. But sometimes they also want to make sure they're following what the doctor says, and to know that you got to just progress them and make sure they complete this phase before they move on to the next one.
So speaking of that, you say that you kind of, in sending them to PT, you make sure they're following the protocol and things like that. Do you educate them about BFR before you send them, or do you kind of expect that to fall under the physical therapist's purview in terms of what to expect, maybe pain level, how long they're going to be doing it, et cetera?
Oh no, I do. I do talk to my patients, my lower extremity patients anyway. I tell them to expect to be getting BFR, and I quickly, I don't spend a whole ton of time unless they're being consented for some sort of research study. But I briefly mention it, what BFR is, why do we use it, why do we think it works, and I quickly also make sure they understand that there's very minimal reported side effects with it, and that they have every option to not to do it if they don't want to. They don't feel pressure to. But I do mention it ahead of time. And so then when the therapist brings it up, they're sort of like what you do with prehab, right? That they don't, they're not kind of thrown off guard.
Mm-hmm. Yeah, I think that's really important because I think the idea of cutting off blood flow to a surgical limb with patients seems really odd, especially to their parents. So like, you're going to do what? And then when I explain it makes sense. It takes it a little bit off the PT, I think, too.
Yeah.
So
yeah, and I think when you tell them about the BFR, you do put the tourniquet on, but they are still getting blood flow to that lower extremity. Yeah. So arterial blood is still going down. Our idea is just to create it's almost like them doing some sort of anaerobic sprint is what we're trying to build in that leg, but without them running, with them just doing a quad set. Yeah. So I try my best to explain it. It doesn't always come across. They're like, just like you said, you're doing what? But if you try to explain it that way, then, and especially if they're, some of the more competitive kids are like, oh yeah, let's bring it on. I want this. Yeah.
You just mentioned some of the pro athletes are using it all the time and they're like, sign me up. It's great.
Yeah. They're doing it. And, when we look at a lot of the studies, if they're healthy, they're probably not going to get a significant benefit out of this. And, the reason I bring that up is because the Olympics were in Japan, and this is where this all originated from, was from Katsu training in the 70s, which means to train without blood flow. They're talking about how a lot of Olympians are training with this and truly believe in it. I think in terms of muscle hypertrophy, I don't think that's that's going to be a huge game changer. But I think for people that work out and need an off day to still maintain some strength, but in a low resistance way, I think that's where, there might be some potential benefit. But again, we don't really have a lot of data on that.
Yeah, we have, at least in the PLL, I can think of some athletes that use it because they're trying to manage their load. They have known, it's not season one for them. They're, multiple seasons in. Maybe they have a little bit of cartilage wear and tear, and they notice if I sort of push too hard, if I get too heavy in the gym, I swell. But, it just, for them, it just sort of feels like it's been a nice change for them, so that they can work, even though they're not post-op, they're essentially working on their load management. And it's, I don't think there's as much science for that utility, but it really, at least for them, it's seemingly helpful.
Yeah, I don't, and I don't think there's going to be a lot of great data because how are you going to measure that, right? But I do think that if the players and patients feel like, one day I can do I can max out on my leg extension, but if I do that all the time, I got a little patellofemoral disease.
Yeah.
It's not going to feel great doing that, but I want to do leg. I don't want to skip leg day, right? And so they will then, you can potentially use BFR and do it at a very low load, or maybe 10 pounds, and you still get the benefit without having that that sheer effect.
Yeah, that's really important. Like Mary Mulcahy's systematic review showed that like it was like 50-50, like 50% there was some muscle, bulking, and 50% there was no difference. But no difference with lower resistance to me is a win. Like that's still, that's still beneficial, and that was healthy athletes, not even injured athletes. So I do think it still has benefits, but I agree with you. I don't think that the studies, the animal model or the systematic reviews, really support it in routine healthy athletes.
Sure, no, I agree.
Thank you for listening to episode 11 of the Sports Docs. We hope you enjoyed the first part of our discussion as much as we did. On the next episode, we'll continue our conversation with Dr. Eddie Chang and focus on the specific uses of BFR therapy, particularly after ACL reconstruction surgery. Make sure to subscribe on iTunes, Spotify, or wherever you get your podcasts to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod. We love your feedback.